Welcome to today's presentation on antimicrobial stewardship and oncological care. I'm Aliyah Baluch, and we co-authored this, Rod Quillitz and I. It was presented originally on November 5 for the FLASCO meeting that was held in Orlando. I definitely recommend it. There are many tracks, including the pharmacy track, for which we gave this presentation. So without further ado, we'll go ahead and get started. We have no disclosures. Just a little bit of humor to make the day go by. To go over learning objectives, we're going to review risk factors for infections in the oncology patient population, discuss the impact on infections by multi-drug resistant organisms on our specific patient population, review the concept of stewardship and the most recent IDSA guideline and upcoming JCO or Joint Commission standard, describe the implementation of stewardship in an NCI-designated comprehensive cancer center. So this is kind of just to get people thinking, is like, what are the following bacterial infections most problematic in your institution? Organisms like VRE, staph organisms like MRSA, Visa, H. Visa, the multi-drug resistant gram-negative rods, whether it be ESBL mechanism, AMC, hyperproduction, carbonase producing. In Symptobacter, this traditionally is surrounded with the issues that occur in a burn ICU in Pseudomonas or multi-drug resistant Pseudomonas. Then, also to make you think, was the status of stewardship at your own institution or one of your many institutions, that there is no formal stewardship and have no plans. At this juncture, actually, this shouldn't be an option because of what JCO is telling us. Stewardship is still in the planning stages. Stewardship exists but has minimal involvement in oncologic patient populations. This, unfortunately, is a majority, in that formal ASP exists and is actively engaged in the care of oncology patients receiving antimicrobial therapy. So this is actually the status at my facility. So also utilizing pretest questions to kind of get everyone thinking even more was the primary purpose of stewardship: institutional adherence to joint standards, reduce costs, improve patient outcomes, manage critical antibiotic shortages. Which of the following are key components of a stewardship program? Pre-authorization of restricted antibiotics. The VA is very good at this. Prospective audit and feedback. Antibiotic cycling. D is all of the above. E is A and B. The next question is, which of the following are mandated in the proposed Joint Commission standard? Multidisciplinary teams, antibiotic data reporting and quality improvement activities, institutional leadership support, staff and practitioner education, patient and caregiver education, all of the above, or lastly A and B. So back to our learning objectives, we're going to review some risk factors for infection in the oncology patient population. In general, whenever you have an invasive line, this is an infection possible source because you've broken your largest organ that protects you, being your skin. So whether it's a peripherally inserted central catheter, a port, a tunnel catheter, which is more advantageous than a non-tunnel catheter. There are very good articles describing fever, neutropenic fever, and mucositis, that when you have the disruption of the gut, then you have increased risk for translocation and thus infection. Low IgG status allows you to have increased risk for encapsulated infections. Anatomical issues related to tumors, not to leave the solid type of cancers out of the discussion, that if you have an obstruction in the liver, you get increased bilirubin, you can get an abscess formation. If you have a tumor eroding into the blood system or a different type of area of the body, you can have rupture, hemorrhage, a lot of other very dangerous complications. When we from ID look at a patient in a cancer facility, we divide them into like high-risk neutropenia versus low-risk neutropenia. High-risk neutropenia is when we talk about neutropenia greater than 7 days, like malignant heme patients, stem cell transplants, whether they're auto, they're cells to themselves, or allos, being cells from someone else to them, and then CAR T patients, which is a type of immunotherapy that's up and coming. Neutropenia low risk is less than 7 days or low IgG. This is your regular solid tumors from oncology sector or CVID. For those of us that don't do bone marrow transplant every day, this is just kind of a neat cheat sheet about how we think when someone needs a transplant, whether it's for aplastic anemia, high-grade MDS, or AML with poor cytogenetics. We first look at family members with 4 swabs in their cheek, looking for a match with HLA. Ideally, the best is a match-related donor. Then you can see the breakdown that we look also at the registries, whether in the U.S. or internationally. And then if you can't actually match or be mismatched from an adult, we will look at the cord registry to see if there's any potentials there. When we look at our patients, especially in transplant, because there's so much data, we look at this net state of immunosuppression. On one side, you have all the immunosuppressants to decrease the risk of graft versus host disease or rejection. So you have your steroids, your calcineurin inhibitors, mTOR inhibitors, monoclonals. And then on the other side, you have all your infectious risk and secondary cancer risk. And you're trying to create a balance where your transplant is working with your patient without killing your patient. The reason I like this graphic from Dr. Tomlin's paper in 2009 is it shows that when you infuse the cells, like which cell line comes up first is the neutrophils. This is why we use this as a benchmark for discharge. But understand all those other cells just take longer, of which the CD4 count in red, it takes a long time. It could be years, especially utilizing certain monoclonals will cause an even more prolonged reconstitution of your immune system. This is just in a different style of graphic. Talk about neutrophil recovery, that not only is your general how long it takes you to engraft, but depending how you got your stem cells also affects how long it's going to take for you to engraft. For example, if you have a marrow graft, it's going to be 3 weeks. Those are all our donor samples that come from Japan, are all marrow grafts. And then on the right side, same thing like in the previous graphic, that monocytes come first, then neutrophils, and then last traditionally is platelets. I love this graphic, actually. It's one of my favorite because it breaks it down that if from day 0 to 15 to 45, it's all about mucositis. So you could relate this to a malignant heme patient. As they get chemotherapy, it disrupts the mucosa, so that's going to give you gram-positive and strep organisms, mainly from the mouth, gram-negatives from the GI tract, HSV, which is a stress-related reaction, Candida because of gut disruption, and this dictates your prophylaxis. Then 15 to 45 to 100, this is after you engrafted and all the different cell lines are trying to figure out what it's doing. You still have a relatively restricted T-cell repertoire, so you start having reactivation issues. And you can see also here that this also depicts that traditional 14 days of neutropenia before you have increased risk for mold. And that after day 100, you have a variety of other issues at risk where finally your B cells and CD4 cells are trying to recover, but they're not necessarily very smart. And this is just a graphic showing again that based on the infections we see, this is how we choose our prophylaxis. And then looking at the viral stuff, again, infection prevention is a huge issue to decrease your risk of exposure to respiratory infections. And this is just reminding us that pneumocystis prophylaxis also, for example, statistically, for us, we don't start until day 28. What about colonization or previous infection? How do you test for these things? So with MRSA, you would do a MRSA PCR. With VRE, you do a VRE PCR. To know if someone is colonized with strep viridans, you'll be looking at previous cultures. If you're looking for someone to be colonized with resistant gram-negative rods, which kind of ties in with the next one, either you have previous blood cultures from the last time they were neutropenic, or as in the case with prostate cancer patients or prostate workup patients, you go transrectally to get to the prostate. And they do multiple biopsies, so of course you're going through the mucosa of the rectum. So what we're doing, because we found if you just gave the previous standard, which was just prophy with fluoroquinolone, people were having all these bacteremias that are fluoroquinolone resistant. So we started to do swabs of this same area to look for this resistance, and if it was there, then it would generate a culture, so we knew what better drug to give prior to getting this transrectal prostate biopsy. This was just a table that I snagged from the Baker paper talking about different mechanisms of resistance and recommendations. For example, ESBL should be treated with carbapenems. AMP-C, carbapenems, cefepime, or fluoroquinolones based on your susceptibilities. CREs tends to be a bunch of different combination therapies. MDR Pseudomonas, of course, an anti-pseudomonal. Acintobacter tends to use a lot of polymyxins and minocycline. Steno, innately multi-drug resistant. That's why it's selected out from prolonged exposure to carbapenems. And the drug of choice is Bactrim, and a few other options come behind. And this is just pointing out, the spice bugs. These are all very dangerous multi-drug resistant organisms. This is a different mnemonic looking at other kind of ways to remember drug-resistant organisms. Ephesium, there's now unfortunately daptomycin and linezolid resistance. Staph aureus, we have also dapto and linezolid resistance. Klebsiella, it has quite a variety, whether ESBL or CRE. Acintobacter tends to have a lot of resistance issues, but thankfully we tend to treat it often with Ampicillobacter. Pseudomonas and Enterobacter also issues. Enterobacter, consider using more your fluoroquinolones rather than a drug like Piptazo. And then why do I even bring this up is the fact that it's known that bloodstream infections with ESBL producing organisms is an independent predictor of mortality, prolonged length of stay, delay of appropriate antibiotics because your lab is either rerunning things or having to set up modified Hodge plates or other issues, and then also total stay also goes up in price. This is a nice graphic just reminding us actually different areas of the world based on the drugs that are being used not only in the hospital but in the environment, in pesticides, and in the food supply is dictating what type of bugs we have. So for example, the United States and some of South America, it's all about KPC. But if you go to Pakistan and India, which is in green, this is all about New Delhi metalloproteinase, or NDM1. There was a white paper published on carbapenem producing gram-negative rods, unfortunately showing that polymyxins is usually an antibiotic that works in the outer membrane of the bacteria, which should lead to death of the organism. But then we have now MCR1 gene, described initially in 2015 as plasmid-mediated colistin resistance, so super, super bad. Unfortunately now seen not only in animal and environmental sources, but in humans, and that they reviewed more than 21,000 samples of E. coli and Kleb, but thankfully only a 0.1% prevalence. But the idea is to try to use stewardship to decrease our rates of resistance and transmittance in the hospital. So obviously this is my little point of humor, trying to remind us this is danger. This would definitely, for a patient, say, who is in the hospital, cancer hospital, already on nephrotoxic drugs, it's really bad that one of our drugs for using for multi-drug resistant infections has resistance. So just kind of reminding all of us, neutropenic fever, you need coverage for Pseudomonas, whether an anti-pseudomonal cephalosporin, Piptazo, or anti-pseudomonal carbapenem. And then once you do that, if you have hypotension, pneumonia, or history of drug resistance, you kind of risk stratify from there. If you have drug resistance, aminoglycosides are very good options. Key elements is, remember, not everybody gets IV Vanc anymore. This is definitely an A1 indication. Do not give IV Vanc for everyone. Unless, where there's a tunnel catheter, there's cellulitis, or some other consideration, then you can consider the IV Vanc. There are B3 indications that if you're MRSA colonized, use something anti-MRSA. If you're VRE colonized, use something against VRE. For us, we interpret this, for example, in my particular service, if you're MRSA or VRE colonized, you get that particular drug for 48 hours. If at 48 hours your blood cultures are negative, we get rid of these additional drugs and continue on the main backbone of therapy, which is, again, that anti-pseudomonal coverage. And we do use this if you have an ESBL history, consider early use of carbapenem. So like for myself, if they have a history of ESBL, actually they're going to get upfront meropenem as their drug of choice. For KPC, a lot trickier because so many of these drugs are nephrotoxic. If you have allergy to penicillin, you need to have a long conversation traditionally with these patients and consider if it's a true anaphylactic allergy and they haven't aged out of it, that a monobactam ring, whether it be aztreonam or ceftazidime, they're both monobactams, but you have to combine it with IV vancomycin to pick up that strep coverage. Again, for us, after 48 hours, we get rid of the vancomycin. So, and this is just reminding us we get rid of it, the gram-positive coverage, because you don't really need it if the patient is stable and cultures are negative. On the flip side, if the patient is unstable, you can consider broadening the coverage. In terms of antifungals, you do need to prophylax if they're high risk, whether it's salvage chemo for acute lukes or allos. You have a variety of different options based on your risk stratification. There are very specific indications for anti-mole therapy, whether it is neutropenia with prior history of invasive aspergillosis as an A3 indication. Patients with more than 2 weeks of neutropenia because now they're at risk for mold. Patients with prolonged neutropenia right before stem cell transplant. So what about stewardship versus fever? This was 307 neutropenic episodes. Rate of adherence was only like 53%. Adherence still showed, or despite the adherence, that there is still a lower mortality with a hazard ratio of negative 0.36 if you were looking at one of the stewardship patients. So, we reviewed the first objective. What about the second one, the impact on our particular patients? You can't have this discussion, though, without understanding, the shoulders that we sit upon. We talk about the lab. So, in the old days, aka my residency, we did blood cultures. It was all about blood cultures, fungal blood culture, AFB blood culture. If we could culture the bone marrow, we did it, or CSF. And this, you would go through your algorithm, gram-positive versus gram-negative organisms. It would take a while between a positive gram stain till you had a pure colony on a plate. And then if you were lucky, then it spat out on a Vitek machine with an organism and sensitivities. Nowadays, we live in the world of rapid diagnostics, endorsed also actually by CMS, for PCR panels. So, for example, the blood culture identification panel, also known as the BCID, has 27 targets. Respiratory panel, 20 targets. GI panel, 21 targets. And there's an increasing number of panels, including the meningitis one. So, let's start about how does this work. They take this little pouch, they have a hydration solution, they put in the sample, they add it to the pouch, to the machine, which is approximately, the last time I checked, $46,000 for a machine, but it does a great job because it mixes all these different PCRs, pieces, and purifies, and then literally with 2 minutes of hands-on time, you don't have to be super precise about your measurement. In 1 hour, you will know if it matches one of these 27 targets on a positive blood culture. So, for example, my tube is being agitated in the blood culture machine. It beeps. They take out a sample. They run it here, as well as run a gram stain. So, I'll get called a gram stain. Dr. Baluch, we have a gram-negative rod. I'm like, okay. Is the patient stable? Yes. Do I have gram-negative rod coverage? Yes. And then we wait that 1 hour to find the ID because maybe then I can stop some of my or other drugs that I can narrow my therapy a little bit or totally redirect my therapy if I missed, the 8-ball and that actually I'm treating the wrong group of organisms. And this is just a quick list showing that there are technically 3 resistance markers that they're also looking at, but it's not complete. That you could still have a KPC that doesn't match that actual PCR that they're looking for. So this is just showing, actually, as with any test, that you want to have reproducibility with your lab tests, and actually the BCID is very good in terms of that. This is just a snippet showing the respiratory organisms. This for stewardship is important because if your patient comes in with symptoms of a URI and you order Levaquin and you order this and the respiratory panel comes back positive just for, say, human metapneumovirus, well, if you're a semi-normal, semi-healthy patient, not a transplant patient, and their chest x-ray is negative, you can actually stop the Levaquin because now you know it's just a respiratory infection and the tincture of time is more important. This is just a snippet of the GI panel, kind of the same idea that whereas before we would take, for us, a send-out test to get the adeno test back, but now I get a sample back within an hour, so that's very advantageous. What's the problem with PCRs? So there's no sensitivity data because there's no culture. All it says is yes, I'm here, or no, I'm not, and that's separate from the price issue. So then there's other rapid diagnostics like the Molotov. The same issue is that this is based on protein fingerprints, so there's no culture. There are additional steps that have to be done in order to diagnose yeast infections. It does not give you any information about sensitivity, just again another test that says yes, I'm here. There are other rapid diagnostics that have been around for a little while, being the Legionella urine antigen, but note this only covers 80% of your Legionella cases for serotype 1. It does not find the other serotypes, but that would be positive on a bronch, for example. And you have to be careful you get the sample before you give the Levaquin because it can be negated by one dose even. Strep pneumo urine antigen is very good, and it's important to find because again it's up to 40% of our CAP organisms or CAP scenarios comes from strep pneumo. There's also the histourine antigen that you can follow this kind of semi-quantitative, quantitative urine antigen while the patient's on therapy. And then this is just looking at performance against criteria for an ideal test. What do you want? You want it to be point of care, you want it 100% sensitivity, you want all the organisms in the same sample, 100% specificity. This is kind of like my utopia, my perfect scenario, but these are just goals at this juncture in time. So, impact on oncological patients. So neutropenic fever rates differ based on your chemotherapy, your disease status. You can see here acute leuks are at the top of the list with 95%. That invasive bloodstream infections in 20 to 25% of these patients. But if you can have early, effective, empiric antibiotics, that your mortality goes down from 21% to 2 to 10, which is actually very good, pretty fantastic. But you need all your tools to be working in order to create this type of decrease in mortality. Heme malignancies, now you have an ESBL, you have a multi-drug resistant organism, your mortality kind of holds at 25%. CRE, bacterial colonization, and infection is on the rise. That we have these hotspots in the U.S., for example, in New York, New Jersey. We definitely know in India there's all these millions of residents colonized with CRE, and that the CRE bacteremia mortality is up to 69%. So, originally for our particular hospital, we were looking at the idea of if we decrease our carbapenem use, would it affect our Steno infection rates? Initially, as we got our meropenem, which is the purple bar, come down, we did have a little blip back up, and Rod's part will speak about that. But we were trying to see, especially in this main period, would we see a decrease in Steno? Would it last? Would it not last? And unfortunately, so initially though it went down, as our meropenem went back up, so did our Steno rates. And similar whether, whichever site you were looking at, blood versus sputum. So, this is actually moving on the rods component, but I'll continue to speak that we wanted to discuss the concept of stewardship and the newest guidelines and Joint Commission recommendations. So the initial guidelines are back in 2007, as you can see, IDSA recommendation on stewardship. And what it stated was that this was a rational, systematic approach to the use of antimicrobials. Why? To have better outcomes, minimize unintended consequences like toxicity, C. diff, and resistance. And the idea was to give evidence-based guidelines so that each hospital then develops their own stewardship based on their needs. So core elements was education, and then guidelines and pathways that you need to think about. What is your epidemiology for your particular area? What stewardship is up in New York is not appropriate for what I have in Tampa. That you should have antimicrobial order forms, streamlining or de-escalation therapy, dose optimization, definitely IV to PO because it tends to be price-wise. And then initially they were having discussions of cycling and combination therapy, but you'll see in a few moments that actually these are the parts that are no longer recommended. So how did we do it? So we did some formulary restrictions in pre-auths. We did prospective audits with feedback, education, guidelines, and clinical pathways. Monitor and provide feedback, whether it's an antibiogram, which definitely any hospital you walk into, you should have an antibiogram annually. Document the impact on relevant outcomes, and utilizing these computer systems for surveillance and decision support in real time. So, your ideal stewardship team should have your ID attending or attendings, pharmacists with dedicated ID training, infection prevention or infection control professionals, hospital epidemiologists, your clinical microbiologists, your information system specialists, because this is all about, now that we have EMRs implemented in each hospital, make the computer system work for you. And then ASP people or personnel should be actively involved with infection control, as well as P&T being pharmacy and therapeutic committees. In 2016, there was an update, as you can see presented on the IDSA website, that yes, you still definitely have pre-auth and prospective audit and feedback, but you cannot just have passive didactic education. You have to have this to and from type of discussions that people, you're really assessing, do they understand what stewardship is? That you have facility-specific clinical guidelines with dissemination to the group, implementation, that you need to reduce the use of antibiotics with a high risk of C. diff. That would be my floor, because bone marrow transplant definitely has a higher rate than the general population for C. diff. Antibiotic timeouts or stop orders. As soon as you have an end date, you implement it into the order. Computerized clinical decision support at the time of prescribing. Cycling is literally no longer recommended, so that is no longer part of the norm. Pharmacokinetic programs for aminoglycosides and Venco, you shouldn't be shooting too high, too low, it should be more mathematical. Alternative dosing strategies for broad spectrum beta-lactams to decrease costs, as long as you have the adequate PK/PD data to support it. Appropriate oral antibiotics for initial therapy and facilitate IB to PO. Allergy assessments and penicillin skin testing is getting an increasing amount of press to implement it, because people come in with these vague, I have a penicillin allergy when I was an infant but I was never intubated type of story. That you're trying to reduce therapy to the shortest effective duration. This requires you to be up to date on all your guidelines. You should have stratified antibiograms, because not only is it different epidemiology per town, there could be difference between, for example, in the Tampa Bay area, Tampa General Hospital, regular hospital compared to their burn unit versus my hospital versus the bone marrow transplant unit. These are totally different types of patients. Rapid viral testing for respiratory pathogens, as I mentioned earlier. Rapid diagnostics for blood cultures, which we have. Serial procalcitonin testing in ICU patients with suspected infections. Of course, the caveat is use it in the appropriate patients. If your patient, you have to know the false positives for this test. Don't use it in fluid overload. Don't use it in chronic renal failure, patients who have recent ATG or active diseases like multiple myeloma. Because otherwise it'll just be positive and you won't be able to use it to differentiate between infection and something non-infectious. They also recommend an antifungal stewardship using items like non-culture-based fungal markers in combination, whether it's galactomannan, beta-D-glucan, or PCRs. That when our pharmacists share their information as to be in days of therapy, not defined daily dose, measuring antibiotic costs based on use. For example, if I'm hoarding 100 vials of drug X, you shouldn't be saying, oh, well, it's based on my bill. It should be, how much did I use this month, not what I'm hoarding or have in my stockpile. Facility-specific neutropenic fever guidelines provide support to providers in decisions relating to antibiotic treatment for terminally ill patients. And then there are increasing information from the Joint Commission. They gave this item that is to be effective January 1st, 2017. So what did they tell us? They told us that the new standard is that hospital has to have an antimicrobial stewardship program based on the current literature. What do you have to have? You have to have organization. You have to educate staff and practitioners about resistance and practices. upon hire or granting initial privileges and periodically thereafter, educate patients and caregivers about appropriate antibiotic use, including antibiotics, antifungals, antivirals, a multidisciplinary team, core elements, as you can see: leadership, accountability, drug expertise, action, tracking, reporting, education. I can see a whole bunch of new jobs being made by this because this is a lot of responsibility and a lot of follow-up. That the ASP is supposed to use approved protocols for policies and procedures, guidelines for these different things like community-acquired pneumonia, skin and soft tissue infections, UTI, C. diff, IB to PO, pre-authorizations required, that you should collect this information, analyze, and report the data, that the hospital takes action for improvement when they find areas that aren't up to par. And then lastly, the last section is implementation. What did we do at Moffitt? So just for those who don't know where we hang out, this is obviously the United States. We're in Florida. We're in Tampa, to be technical, and this is our beautiful hospital on an early morning sunrise. When we first implemented, we had the program named as SMART as our stewardship program. We have a pager. We sent out flyers and information emails. We created a pocket guide saying this is what we talk about. Give us a call, whether you want to speak to our pharmacist or you want to speak to our attendings. We created this stratified way to get your drugs, level 1 versus level 2. Level 1 needed approval either from ID or from SMART. Non-formulary antimicrobials. Level 2 was you didn't need our approval to start, you just needed us for other indications. For example, level 1 restriction in 2012 when we first started was the list of drugs noted. And then 2016, you can see we have continued to become more restricted with our drugs as we've learned different things, as well as we've had different issues. So, for example, cefepime and piptazo, as you can see, you're allowed to get it for neutropenia, but otherwise you need specific indications. Level 2 is, the list is noted before with all our carbapenems. In 2016, the list is kind of readdressed some of these things because you can have like the pull down mycofungin we use as our antifungal of choice for our allo transplants. So that's why there are different caveats. You can immediately get the drug without having to call anyone with stewardship or with ID. So the goal, for example, as is with most stewardship, is to have appropriate drug utilization. So carbapenems was a big gun that we were overusing, and so actually with implementation, we decreased our use by 50% in DOT, which is the appropriate unit. But then you can see, even in the best of efforts, you can get stewardship fatigue, and then all of a sudden our meropenem's numbers started going back up. So then we did the next layer, which is we're going to send out an email to the team about who in the hospital at any given time in the morning is on a carbapenem, and so that we can readdress and we just don't, say continue current antibiotics every day when that list comes out. And we were able to also reduce our use of broad-spectrum gram-positive coverage. As you can see, it came down. Daptone-linezolid and, yes, also IV vancomycin also had an equivalent decrease. So what about cost-effectiveness? And this was what you go back to tell your executive committee for a hospital where, looking fiscal year 2012, which was prior to the program, 2014 was after the program, that we were able to have cost avoidance of over $1 million. But then if you look, the next time we measured our cost avoidance, the amount goes down. Why? Because the first year was all about low-hanging fruit, and that once we got really good at that, each year it's to be expected that these continue to decrease cost avoidance as you continue to be where you should be, where per guidelines are dictating to us where we should be, and that we follow our annual antimicrobial purchases. They overall, even with being adjusted for inflation, that they continue to go down appropriately so, and that most likely we're getting close to where we're going to plateau. Now, there's been ongoing issues within the ID communities, especially here in the Southeast with shortages as noted before, and we keep on trying to figure out the best way to implement appropriate usage without hurting our patients. So for example, we found there was excessive use of cefepime in surgical areas where they could have used other drugs. So it gave us the opportunity to readdress that while trying to keep our cefepime and piptazo still available for neutropenic fever, because honestly, there are not a lot of other options available. Shortages and utilization. This is just a neat graphic showing, so before all the shortages, we were kind of equal between our use of cefepime and piptazo. And then unfortunately here, all of a sudden you can see piptazo had to go down because we didn't have it. So then you can see the amount difference. Then of course cefepime is going to go up. And then as we got more Zosyn available, it comes back up. And then slowly but steadily, cefepime will come back down until we're probably about equal again, as long as we have it available. Unfortunately, another aspect of stewardship is this whole cost escalation, price gouging, for lack of better word, of all these different drugs. So whether it be ribavirin, pyrimethamine, flucytosine, you can see the cost analysis there. Actually, we've done a very good job switching over to oral ribavirin without any problems. Pyrimethamine, is looking at $300,000 for initial 6 months of therapy. There's actually been updates in the guidelines because, we're lucky we can usually get whatever we need, but there are facilities that are in more cost tight scenarios that they can't even get these drugs. So IDSA was able to adjust to reflect this. And then, of course, flucytosine is also increased in price as well. So initiatives with the antimicrobial guide, that this was approved by P&T and MedExec, that we can correct antimicrobial dosing per policy. We're able to continue to do our vancomycin and aminoglycoside dosing and monitoring, that we expanded our IV to oral medication policy. We do have an automatic formulary substitution policy, and that we're looking into possibly antibiotic therapy for infected sites for patients at low risk for Pseudomonas, giving options. We have algorithms for UTIs and pyelo, C. diff colitis treatment algorithm, peri-op algorithms, IR we've re-reviewed, and then culture targeted prophylaxis, like I mentioned, the transrectal ultrasound-guided prostate biopsies has actually been a very good place that we've made improvements. What's kind of a nice side effect is this decrease in antimicrobial adverse drug reactions that we review annually. You can see in 2012 on the far right, we had 163 adverse reactions and we're down to 107. So it's a 34% rate reduction between 2012 and 2014. Have a nice little side effect there. So, in conclusion, stewardship programs are now required by Joint Commission as of January 1, 2017. They intertwine many components in education. That this improves utilization of antimicrobials without an increase in mortality. We have looked at this. It's simply an extra tool for all providers to help navigate the waters with ongoing shortages, especially inappropriate antibiotics versus infections. And that, looking here, Dr. Sandine had shared with us, the UN even recognizes that antimicrobial resistance is a huge issue. This is only the 4th time that they've called a general session to discuss such an item. They previously only called these sessions for HIV/AIDS, non-communicable diseases, and Ebola. So definitely, even on an international setting, they're acknowledging this is a huge problem. So, reviewing our post-test, what is the primary purpose of stewardship? It is improving patient outcomes, is our bottom line, and always has been. What are the following key components of a stewardship program? A and B, because as we mentioned, antibiotic cycling is no longer advantageous and is no longer on the guideline. Or let me clarify, is found to be not advantageous with improved data and therefore no longer on the guideline. What is mandated by the proposed Joint Commission standard? All the above. You should have a multidisciplinary team, you have reporting, quality improvements, you have leadership, you have education of not just staff, practitioner, but also patient and caregiver. And this is just an acknowledgement to say thanks to the SMART team, our assistants, our pharmacists, our nurses, our doctors, infection prevention. We're continually growing to meet our needs. These are our team members as mentioned. And that this is just a couple of addendums. The Moffitt Cancer Center antibiogram as an example of what we do annually. And then just some examples of our resistance profiles. For me especially, the Steno is important that as we decrease our Carbapenem, even if our numbers don't improve with Steno, though they have actually on the two main floors that I work on, the more important is actually our Bactrim sensitivity is coming back from our low of 77, which was very freaky for me. And that is it. And if you have any questions, feel free to send us emails. Thank you for your time.